Well, just a quick introduction on our webinar and presenter today. So Dr. Alexa Pichet Binette is now a postdoc at Lund University. She obtained her PhD at McGill University in Montreal, working with Professor Sylvia Villeneuve, working on neuroimaging and behavior data with relations to aging and especially Alzheimer's disease. During her PhD, she also collaborated with our CSO, Maxime Descoteaux, mainly for the diffusion MRI processing and analysis. And now she continues this work during her postdoc in Sweden. Today she will present her insights and some thoughts on how we can look at Alzheimer's disease, especially with tractography and PET imaging. So Alexa, I'll let you go ahead.
Great. Thanks so much for the introduction and for the invitation. I'm very excited to be talking with you today. And in a way, this is a talk about Alzheimer's and tractography part 2. I know Maggie gave a very nice webinar covering white matter changes over the full course of Alzheimer's disease. And today I hope to provide you with a complementary view, focusing more on the early stages of the disease and amyloid and tau PET. And so before we start, let's just make sure that we have a common definition of Alzheimer's disease, which can be defined as a biological clinical entity.
Alexa,
so yes?
Sorry, let's break because your slides are not moving forward.
Oh, mais voyons donc!
We need to figure this out. So can you share your full screen maybe instead of just sharing PowerPoint? Or
yeah. Actually,
or activate the share while you're in full screen.
Yeah, and when I try to, okay. When I try the screen sharing again, it doesn't give me any options. I feel like I need to log out and log in again. Because when I do the screen sharing, I get only this option of sharing this PowerPoint.
So Alexa, I made you organizer, so you should be able to share most of the things.
But it just does, again, the PowerPoint, not like the full screen, the full computer like we tried in the trial. Okay.
Well, maybe you log out and log back in.
Yeah, I do that. I'm so sorry.
So we are sorry for this slight delay. During all of our tests, everything was working correctly. So with technology now, it seems that we have a few issues. We'll work on fixing that. Thanks for your patience.
All right, let's try this again.
Yes, good job.
Yes, okay.
Yes.
I'm so sorry. And the thing is, I swear we tried this 2 days ago. Well, we have to share the whole screen and not just one application for the future. Great. So at the clinical level, the main symptoms often start with memory loss, then other cognitive domains can be affected. And by the time someone gets a diagnosis of Alzheimer's dementia, activities of daily living are also impaired. But it's important to keep in mind that those are the very late stages of the disease. And before there's any symptoms, there's a lot of biological changes that have been ongoing in the brain, which are deposition of plaques of beta amyloid proteins, neurofibrillary tangles that are formed from hyperphosphorylated tau proteins that is also accompanied by neuronal loss. And so all these changes start to occur in the brain in what we refer to as the preclinical stage of the disease. And this has been really the main focus of my research so far, trying to understand what are the early brain changes in Alzheimer's disease. And a lot of the clinical trials or interventions are really moving to this asymptomatic phase of the disease to try to stop the pathological changes as early as possible. So I think it's important to try to understand what's happening. And for the purpose of this talk, I also mentioned that there are two forms of Alzheimer's disease. The most common form is sporadic AD. Most cases occur late in life, and this is as a more multifactorial causes. But there's also a rare form of the disease that is caused by a genetic mutation that leads to the overproduction of those amyloid proteins. It's called Autosomal Dominant AD or familial AD. And thinking again of this preclinical stage of the disease, this familial form of Alzheimer's disease is very interesting because we know the mutation carriers will accumulate amyloid and eventually develop dementia, often already in midlife. While in sporadic AD, when we study cognitively normal older adults, it's very hard to know who will develop the disease or not. And so we tend to focus on the participants who are amyloid or tau positive, because those are the ones at greater risk of progressing to the disease. And so trying to, again, understand what's happening early in the brain, there are two projects that I'd like to share with you today. The first one where we focus more on gray matter changes, and the second one we focus on the microstructure of the brain in relation with amyloid and tau. And for all these projects, we use different tools from neuroimaging to be able to look at all these pathological changes in the brain. So for neuronal loss, we look at, we used structural images, T1 weighted MRI. For amyloid and tau, we now have ligands to do positron emission tomography to really know where these proteins are in the brain. And amyloid-beta has been around for a while now, but tau-beta is quite new, and this has been really transformative in the field in the recent years. And if you're here now, you might be wondering, okay, but what about white matter? And I think this is more an open question of where the white matter microstructural changes might fit in this timeline. I think we have good evidence that there's changes that might be occurring early on. And again, for a good coverage of this topic, I recommend Maggie's webinar again. And here the approach we took was to look at changes in relation with amyloid and tau, and I'll get back to this when we get to the second project. But first, let's start with gray matter changes. And in Alzheimer's disease, we know the hippocampus is very much affected. It has a lot of atrophy. But given that most of those cases occur later in life, there's a lot of brain changes going on that are also related to just normal aging. So trying to disentangle which features might be related to aging versus early signs of AD is not so easy. And the approach we took to answer these questions was to look at more lifespan changes. So we wanted to identify gray matter features that would be specific to AD, so not changing with age, but with the disease. Whereas conversely, there might be gray matter features that change with aging, but not further with Alzheimer's disease. So those would be specific to aging. And of course, there might be features showing this additive effect. And so to answer this question, we aggregated data from multiple open access data sets. So we ended up with more than 1,000 participants that are from which we have two groups of young adults, two groups of cognitively normal older adults, and two groups of people who have the clinical symptoms of Alzheimer's disease. We generated a gray matter map of all these participants, and then we wanted to use a data-driven approach to generate gray matter networks that would be representative of our whole sample. So we decided to use independent component analysis, from which we had 30 networks, and we refer to them as morphometric networks. And those are the features we use then to do further analysis. So you see all our networks here, And I think already we can appreciate that many of them recapitulate very well-known anatomical regions. For example, we have a nice cingulate cortex here, precuneus here in 9. And then using gray matter volume in all those networks, we wanted to see which one would best discriminate young from older adults. So this will always be shown in the blue curve on the ROC plot. Whereas on the other side, which network would best discriminate older adults from Alzheimer's patients? And this will always be the red curve. And so here are the results for the 30 networks. And I know this slide is busy, but I'll point you to the key ideas here. So looking on the aging effect, the regions specific to aging are really these frontal networks, with the first one being the best one, being able to discriminate between young and old, but not so much with the disease. On the other side, our best network related to Alzheimer's disease was our network number 10. I'm sorry, I have the go-to panel, but the number 10, right? This medial temporal network. But there we see that even though it is good at discriminating old from dementia, it's as good to discriminate the young from the older adults. So we have an effect of both aging and Alzheimer's disease in this network. And the results are summarized here on our glass brain. So for the aging effect, we see many networks are showing a good discrimination, with our key networks showing that gray matter volume is reduced from young to old adulthood, but not much further with the disease. Whereas on the other side, we only have 2 networks from which we can differentiate old from AD dementia, but the gray matter there shows an additive effect of both. And I mentioned also how the preclinical stage is very important to us. And so if I repeat the same analyses, splitting our group of older adults between those who are amyloid positive or those who don't have pathology in the brain, the results are not changed. So just gray matter volume is really hard to find early signs of the disease. And in another step of the paper, we also wanted to see whether some of those features would help us discriminate older adults who remain cognitively normal versus those who progress to clinical symptoms. And for that, we took advantage of a subset of those older adults who were followed over time, and some did develop the symptoms. And so we checked which features would best discriminate these 2 groups, looking at gray matter volume in our top aging or top AD network, or a measure of whole brain organization across those 30 networks. This was another part of the paper. But the key idea here is that this whole brain pattern measure was the best one to discriminate those who remain normal versus those who converted to the disease. And so just using gray matter volume features, it is very hard to identify early signs of Alzheimer's disease. And so that brings us to think of other MRI parameters that we could look at to try to identify early changes. And we turned to looking at a white matter microstructure. And we really wanted to see whether some of the key regions in the brain related to amyloid and tau pathology would show signs of microstructural alterations. And the rationale for this idea really stems from the idea that pathology is spreading through connected regions, and from knowing the spatial pattern of where amyloid and tau starts to deposit in the brain. And so let's look at this pattern together, and then you'll see better the motivation for this project. So let's start with amyloid. If that in this cartoon you see where this protein starts to accumulate, and already in the preclinical stage of the disease, we already see this widespread pattern of amyloid, with some key regions being in the frontal, parietal region, and then extending to the temporal lobe. And this is very similar to those default mode network regions, if you're familiar with functional imaging. Looking at tau, the pattern is very different. Tau has a much more focal deposition. we can start to detect tau pathology with PET first in the entorhinal cortex, then the hippocampus, then it spreads to the rest of the temporal lobe, but it is really only in the late stages of the disease that tau is present, like in the whole neocortex. And if you're familiar with brain anatomy, you might start to see that those key regions where pathology is present are connected by very well-defined white matter fascicles. So if we look at amyloid, we see our key frontal parietal regions are connected by the anterior portion of the cingulum. There's also the uncinate fasciculus that connects our frontal and temporal regions. And if we look at tau instead, given how it is really present in the temporal lobe, there is now the posterior portion of the cingulum that might be very related to the spreading of tau. And all those bundles or those brain regions have been shown to be affected across the spectrum of Alzheimer's disease. But a lot of the work had focused on comparing, let's say, cognitively normal adults with MCI or AD patients. And across the disease, we see a typical pattern of white matter degeneration that would be captured by a decrease in fractional anisotropy and increase in mean diffusivity. But focusing on the preclinical or the early stages of the disease, it's not so clear how microstructure and pathology might be related together. So this is really what we wanted to target here. To do that, we used two cohorts. So we had our Prevent AD cohort. This is a study that enrolled cognitively normal older adults who are at greater risk of sporadic AD because they all have a family history of the disease. And this is a study at McGill that has been going on for more than 10 years now. And on the other side, we wanted to look at mutation carriers of this familial form of Alzheimer's disease to see if in both forms we might see similar results. And for that, we had access to the DIAN consortium data. A key difference between those two cohorts in DIAN, participants are much younger due to the etiology of the disease that starts very early in life. And there's also a greater proportion of people who are amyloid positive in DIAN. Then we had amyloid in the familial form of Alzheimer's disease and amyloid and tau in people at risk of sporadic AD. So we processed the data similarly for both cohorts. And here I used the nice tools from the SIL lab and some from IMICA. So I'm very grateful for this ongoing and fun collaboration. We first reconstructed the whole brain tractogram for each participant, from which we then extracted our bundles of interest, which are the anterior cingulum, posterior cingulum, and the uncinate fasciculus. And in all these bundles, we were interested in different microstructural measure. Here we decided to look at a free water corrected measure of diffusion tensor measures. And so by removing the contribution of free water, the idea is we might be getting a more precise estimate of the tissue fractional anisotropy, mean diffusivity, axial and radial diffusivity. So we had those measures in each of those bundles. On the PET side, for amyloid, we had a global score that covers the frontal, parietal, and temporal regions. This is a very typical way of analyzing amyloid PET. Whereas for tau, we decided to focus specifically on tau in the entorhinal cortex, given that our participants are very early in the disease process, and this is the key region where the pathology is starting. Then the idea was to look at the association between our microstructural measures with the amount of pathology in the brain. And we focused also specifically on those participants who were amyloid or tau positive, given that those are the ones at greater risk of progressing. So first, let's look at the results in DIAN. You see an example of the data here, looking at fractional anisotropy on the x-axis, and the y-axis represents the global score of amyloid. And it's already very clear that it is really in those participants who are amyloid positive that we see an association between the microstructure of the different bundles and the amount of pathology in the brain. And we repeat these analyses for all our measures of interest, which are shown on the y-axis, and the bar graphs now represent the strength of the correlation coefficient. And the main results we're seeing here in the anterior and posterior cingulum, and we can see that the pattern of association is also very consistent in both bundles and depicts the typical white matter neurodegeneration pattern. So there is a decrease in fractional anisotropy, increase mean diffusivity and radial diffusivity with more amyloid in the brain. If we now turn to the PREVENT-AD cohort, the results are presented the same way. This time we see the main bundles where we see associations are in the posterior cingulum and the uncinate fasciculus. And looking across our different diffusion measures of interest, again, we see the same pattern of associations emerging, suggestive of microstructural degeneration in those participants who already have pathology. We had tau PET also in the PREVENT-AD, and they are the only bundle where we saw associations were in the posterior cingulum, which again is very in line to where the tau pathology is present in those participants, and again with the same associations, same pattern of associations across the measures. And so overall, in 2 cohorts in the preclinical stage, both of people at risk of sporadic AD or pre-symptomatic people from the familial form, we see that there are microstructural alterations that are accompanying the presence of pathology in the brain. And I think it's important also to mention that if we look instead, let's say, at gray matter volume in key regions connected by these bundles, we don't see any associations with pathology. So again, suggesting that by using new tools like tractography or tractometry, perhaps we're able to capture more of these early changes that are going on in the brain. And of course, now I've focused a lot on the amyloid and tau, and I think these markers are definitely important. They are required for a diagnosis of Alzheimer's disease, but there's also, it's even more recognized that there's a lot of heterogeneity in dementia, and a lot of new biomarkers are being considered and available, especially with the advent of more recent blood biomarkers. And a lot of them suggesting of different pathways, not just amyloid and tau, have been related to microstructural changes. One of them is actually related to axonal injury, and there's really nice work relating the white matter changes with this marker in Diana, actually. And so if we can take advantage of more of these markers, perhaps we can broaden our understanding of the early changes in the disease. And again, related to this heterogeneity in the disease, now more related to tau PET, there is this recent study published, I think now a week or 2 weeks ago, suggesting that perhaps our pattern that we can detect with tau PET is less homogeneous than what we thought. Using data from more than 1,000 PET scans, there are 4 subtypes that have been proposed showing different pattern of tau deposition, and all these subtypes are all equally well represented. So with this idea again that perhaps with tools like tractography we can really track the disease progression, perhaps we'll be able to go more at the individual level and really understand better what is happening in the brain. And this is some work that I hope to pursue now during my postdoc. And so with that, thank you all for your attention. I'll be very happy to take your questions and continue to discuss with you. And of course, I want to acknowledge our PREVENT-AD participants, Diane participants, and consortium as well for sharing the data with us. A big thank you to Max and the STIL Lab for all their help. And a lot of this work really came from my PhD, so I'm very thankful for my supervisor, Sylvia Villeneuve, who is a great mentor. So thank you.
Thanks, Alexa. Okay, my camera is back. So we're gonna take questions now. So I see that a few questions are popping in the questions panel. If you want to ask it directly, you can also raise your hand and we will go to you. So the first question is from Maggie. So you reference her talk in your talk. So she's asking, tau is also accumulating in the white matter, such as along the fornix. Do you believe there is an appropriate tau PET tracer to really investigate the tau accumulation along the white matter bundles?
Yeah, that is a very good question. And the tau is really this microtubule associated protein. So in theory, it would be nice to be able to capture this with the PET. I think that the PET tracers are really more at the end stage where the tangles are formed. So I think it's a bit hard to know how well the tracer itself could be analyzed in the white matter. But that being said, the fornix and the hippocampus is very important. And one caveat that we have with the current tracer that we have is it has a lot of non-specific binding in the hippocampus. So probably to maybe iron or binding from the choroid plexus that contaminate the hippocampus. So it's really hard to have a good signal there. But there's new tracers developed with tau that are more and more used. So I think probably with those tracers, we'll be able to look more into the hippocampus and potentially the fornix as well.
Thanks. Another question from Jens Werfel. Well, first he said, brilliant talk, Alexa. Could you imagine that we use diffusion to disentangle the degenerative from the inflammatory components in the white matter?
Yeah, it's a really good question. And I have to say, I'm not an expert on diffusion, but we have really good experts on the call, so they can jump in. So with this idea of like the free water index here, we did not see associations with that, but perhaps this might reflect some inflammatory processes going on. And again, there's nice work from Imika, the STIL lab, showing how this across the full spectrum of the disease is increased. So I think probably with, again, new sequence or new ways of analyzing the data, there is probably a way to get closer to the inflammation. And at the same time, I think, especially in CSF and now in blood, there's a lot of inflammatory markers that we can measure. So I think trying to relate that with our MRI measures could be interesting.
Thanks. So I'm just looking if there are other questions live. Not here. So, a new question from Jade Lasselbe. What software did you use to obtain the tractography?
Yeah.
So maybe on the details of the methods, I guess.
Yeah, totally. So we used Tractoflow that Guillaume here developed. So this is, again, freely available. There's really nice documentation if you want to use it. And it's very nice because really it outputs the TI map, some maps of more advanced metric that are relying on the fiber orientation function and not just the tensor, and as well as the tractography as the end stage. So this is a very complete software. And the tricky thing here, it's not tricky, but the difference here, we used also now what is called the atlas-based segmentation version of Tractoflow. And there the tractography is maybe using a bit less advanced
technique.
Sorry?
The technique, the tractography.
Yeah, exactly. Technique. Thank you. I lost my word. Yeah, exactly. A less advanced technique of tractography. But because we have older adults who are starting to show atrophy, and there's a lot of region, especially with the Angstnet fasciculus, where it's like a bit of a bottleneck. It's really small where the fibers are curving. And so with the more advanced technique, it was hard to get nice bundles. So we used Tractoflow ABS. And again, you can go on the GitHub page and it's there. And yeah.
Perfect. Thanks. So I'm sorry in advance. I'm going to try to pronounce the name. So Mikolai Paulak is asking, would you be able to comment on the cerebellar involvement at some stage of the Alzheimer's disease? if you are able, then when would it be involved?
Yeah. This is a nice question. I had this in my defense as well. They're like, yeah, you never look at the cerebellum. So it's a really good question. I have to say, I think we are a bit guilty of never really looking at the cerebellum. I think in terms of the accumulation of those pathological proteins, it is very late in the disease process. Regarding more like, let's say, gray matter atrophy or microstructural changes, I have to say I don't know any specific work that have looked at this. I would say for sure that it is late involvement. And another tricky thing is often, I say, especially in Diane, for example, the cerebellum was cut often a lot regarding the diffusion data. So it's also hard sometimes to even be able to look at it in a very nice way, even if we would like to.
And then I think it's a follow-up question from the same attendee. So he said, these were excellent results that show reliable results on diffusion data. Do you think that we should use the same settings, so the same spatial and directional resolution to get reliable results? So I guess that's in the cerebellum again, using the same settings or same acquisition in the cerebellum.
Well, I think as long as how the person is positioned in the scanner or so on includes the cerebellum, then for sure in the same framework of analysis that we use, we could totally look at the cerebellum, and probably some of the tools used to extract the bundles would also yield the cerebellum. I didn't look at this, sorry. Yeah. And that regarding the parameters or the acquisition here, in both cases, it was very standard diffusion sequences, and I think this can yield really nice results. Then you have depending if we think of a research or a clinical setting, then we have to think how far we could push this the sequences, but with more advanced sequences, also maybe we can even get closer to even more precise microstructural measurements.
Perfect. So now one from Duncan Knowling. First, excellent talk. For studying early stages, how exactly do you define the preclinical AD and who is included? Primarily looking for early amyloid and tau biomarkers, or have you considered identifying those who might fall in the subjective memory complaints but may lack the early amyloid and tau deposits?
Yeah, this is a very good question. So in this work here, we really focused on people who would be considered amyloid positive based on this widespread pattern of amyloid. And this is really what is required, actually, if we follow the typical definition of preclinical AD. It starts with being amyloid positive, then you could become amyloid positive, tau positive, and so on. So it was really based on the pathology. And for amyloid, we know very well who can be positive or not. It has very bimodal distribution. For tau, it's really ongoing discussion, and it's not so clear-cut. Here, as I said, we chose the entorhinal cortex, and to have a measure of tau positivity, in this case, we chose the top 20 participants who have high tau, and because those are also likely, most of them are also amyloid positive, so it makes sense with the progression of the disease that we know. But so yeah, that's for the pathology. Then for the SCD, subjective cognitive decline, we did not consider it here, but this is definitely something that we are investigating. We ask every year almost our participants if they think their memory is declining, if they are worried about it as well. So that could be even SCD plus according to certain criteria. I've shown basically that, let's say, looking at functional MRI, those SCD participants were showing some alterations. that was a long answer just to say I think it's really important to look at this SCD, but we did not do it specifically here, but this is work going on in the lab.
Thanks. Another question from Jimmy Gaziri. Well, first again, very interesting talk. I just want to make sure I understood how your data was compared from a methodology point of view, since they came from different sources or databases, so the MRI acquisition might not be exactly the same. I understand groups were analyzed separately, but how were the data and results compared?
Yeah, so I guess this would refer more to the first project where we merged everyone together. And you can clarify in the question if that's not the case. And this is a very good point. Oh, sorry. And what we did, so everyone was processed through, we used Dartel here to generate a common template. And we were very careful. I have to say, everyone used a similar T1 sequence. And we were more careful to make sure that this common template that we generated was really representative of our participants. So we first generated a template of young adults, older adults, and AD, and then made a common template from that, from which we registered every participant to try to reduce a little bit the bias that we would have if we directly merge young and AD patients to the same template. So I think this we were very careful. We did the analysis many different ways, even extracting the gray matter networks and so on, and results were always consistent. So this is how we dealt with it, more in like how we thought about those gray matter maps, but at the first level, we did basic steps to make sure that they were homogeneous and so on.
Perfect, thank you. So for now, I don't see any more questions. Anyone wants to ask a question directly through your mic? If I unmute you. Oh, I see Maxime is there. Do you have a question, Max?
Yeah, I might jump in quickly, Alexa. Thanks for presenting. Very impressive work. You're being very humble because your eLife paper is no longer under revision.
True.
Is accepted. I'm surprised you didn't mention. But so very nice work, and so this will be out soon for everybody online in eLife. So very proud of you and nice work. But let me ask you this: if you were to dive in even more into the microstructure part of the white matter and tractometry, because right now you're showing very nice association between, you know, a beta positive and you know, some white matter features, but these are just associations. If you were really going deep down into these bundles, into the white matter, and looking at the microstructure indices of diffusion, what would you expect? Would you expect to be able to discriminate these two groups just by looking at their diffusion signature? And if you had another year to dive into this data, what would be your, you know, what would you look at above all or in priority?
Yeah, a really good question and an important question. I think the next step I would try to do would actually try to look at it longitudinally to see. I guess the idea is if we think, again, the microstructural changes might be related to pathology spreading in a way. I know this is very far from the actual spreading, but still, then I would wonder if, let's say, those, because we are people who are, let's say, amyloid accumulators kind of in the prevent AD, and we're going to scan them next year, actually. So I think being able to see whether there are microstructural changes that might be exacerbated in the ones who will then accumulate the pathology, for example. This is what I would be very curious to see. I think, yeah. And again, this I think will really help us understand when is this happening, right? I think now that what the results we see are in the people who already have a lot of pathology. And so I think this is nice and very clear results that those changes are present early on, but to understand a bit more the timeline, yeah, this is what I would like to try next.
Cool. And another maybe more futuristic question is, and you kind of showed a bit of that with your gray matter analysis, where you use network ideas, right? You use ICA to find networks of gray matter and study gray matter differences at the network level. What about doing that with diffusion, with connectomics and networks of white matter, and then combining that with networks of tau or A-beta, and go to the next level where we're not just looking at just a single track, but networks of tracks, or yeah, the more of graph theories, connectomics. Yeah.
I think this is definitely of interest. One thing in the lab is supposed to do that during her PhD, so let's see. But I think definitely, especially we are looking at very subtle changes. So I think taking advantage of more the whole brain, and with the gray matter project, this is really what we see. It's looking at the relation between all those networks. When there's a disorganization, this might be a sign of early risk of the disease. So I think same thing with the white matter, being able really to look at the connections between all different regions in the brain might give us a better indication, and might also be able to tease apart a bit better those individual differences, because perhaps again it's not the same regions exactly for everyone that will be affected, especially maybe with tau, even if we believe those subtypes. So yeah, this will be is very important as well.
Cool, because we have tools to try to do this.
Yes, so yes, continue talking, and please keep me involved.
Last question from the audience, from Greg Operto, where it says, great talk. Did you have the chance to look at nonlinear relationships between amyloid burden and white matter microstructure integrity? Yes. For instance, recent results published by colleagues et al. Show that low amyloid burden is associated with increased FA, but decreased MD, RD, and axial diffusivity. So, you want to comment?
Yes, this is a very interesting question. Good good last one, I guess. So maybe this is a bit controversial. Sorry. Actually, when we tried to look specifically at the endpoints of the bundles instead of global amyloid and so on, in the prevent AD cohort only, we saw this non-linear relationship that you are describing. So the opposite pattern, right? So there would be more FA, less mean diffusivity, with more amyloid or tau at the voxel level at these endpoints of the bundles. That being said, so I think this is definitely possible. There's again nice work again from Barcelona showing this, and we addressed this in the discussion. So I think this is very possible. I think the technique we used before maybe was a bit contaminated with the gray matter, white matter, bleeding with PET, and so I think it was and I could not replicate this result in a second time point. So this is more tricky, but I think it's definitely possible. And I think, yeah, with maybe more precise tools, we can tease this apart. Here again, if I take people who would be considered more intermediate on amyloid, there is none of these typical degeneration pattern that we see. It's really the ones who are clearly positive. So again, maybe in those, there might be this non-linear association. So I think it's really important, again, yeah, to sometimes maybe not always go, yeah, the whole group level, but yeah, seeing with these different level of pathology, what might be happening. So I think this, again, a long answer, but something to keep in mind for sure, although looking at global measures of pathology, it is very clear here, at least in these two cohorts, this is the typical degeneration pattern that we can detect.
Maybe a last question for the road, and then I'll close the meeting. But another question from Nikolai that says, to what extent do you think these changes you observe with diffusion correspond to small vessels?
Yeah, totally. I think this is all really important to keep in mind, yeah, when we're looking at white matter or diffusion imaging. I have to say, in general, just in the Prevent AD cohort from the work I've done with those in the other project, I don't think this would play a big role at this stage. And in Diana, I did not look at this in a lot of detail, but because they are younger and we're also looking at people who are only cognitively normal, I think, again, this would not play a major role. But in general, I think this is very important to consider. And I think if I could, I didn't have time, but then we thought like, oh, can we have, let's say, flare data or whatever? So I think it's important here. I guess it would not affect so much the results.
Great, thanks. So I'll pass it on to JC, and thanks, Alexa.
Yeah,
thanks
again. Really great presentation and great answers to all of the great questions, in fact. So I have nothing more to say except thanks everyone for being here. We will share the video as soon as it is processed. And remember, if you can quickly answer the quick survey that we will send, it really helps us for the future webinar. So again, thanks everyone, and especially thanks to you, Alexa, and see you soon.
Thanks a lot. Bye-bye.
Bye.